Prego.
Ok, sto cercando di far partire il recording, dice... Ok. Good evening, everybody. We're back with a new season of the Journal Club. We have many things planned. We have all the next 2 months are already planned with a lot of interesting things. And we're going to start tonight with a very diverse presentation given by Francesco Rubino, who is a thesist in orthopedics at Galeazzi. And he specializes and is interested in the differences between minimally invasive surgery and traditional open surgery. So we will have a diverse presentation, slightly gruesome, funny, and very interesting as well. So the stage is yours.
Okay, thank you, Pietro. Good evening, everybody. I'm Francesco Rubino, and today I'm going to talk about the minimal invasive surgery in orthopedics. Okay, let's begin. So today we will see the carpal tunnel surgery and the carpal tunnel syndrome, the arthroscopic anterior cruciate ligament reconstruction, and the unicompartmental knee arthroplasty. All these three topics will be explained with a focus on the minimal invasive approach. Okay, so we can begin with the carpal tunnel surgery. So the carpal tunnel surgery is the treatment of the carpal tunnel syndrome, which is the most common peripheral nerve compression syndrome, which is caused by the compression of the median nerve, as you can see from this picture, at the level of the wrist, due to the fibrotic transverse carpal ligament. Okay, the typical signs and symptoms of this condition are the tingling sensation at the level of the hand on the area supplied by the median nerve. So the first finger, the second and the third finger, at the level, palmar fingers. It can also present with burning sensation. And typically, if this condition is not treated early on, it will cause atrophy of the thenar muscles of the hand. Okay, to make the diagnosis, we use the signs and symptoms, which are quite peculiar, and also two types of tests, which are the Tinel test, where you hit the transverse carpal ligament with your finger, and in that way you would elicit a paresthesia, or the Fallen sign, where you ask the patient to flex their wrist in this position, and also in this position you would elicit paresthesia. Okay, the treatment is to cut this transverse carpal ligament and thus releasing the compression on the median nerve. This picture is not the surgery to treat the transverse carpal ligament, but I decided to put this picture in this presentation because in this way you can see the real anatomy, and also you can see how crowded is the carpal tunnel. This is a median nerve, which looks like a linguina. This is a branch of the median nerve, probably the palmar cutaneous branch of the median nerve, and here we have all the different flexors. The transverse carpal ligament in this picture is not easy to visualize, and it is located at this level. Okay, so you can imagine why, when the transverse carpal ligament becomes fibrotic, the first structure that suffers is the median nerve, because it is the most susceptible to compression of these structures, and it is located in a very packed area of our body. Okay, for the treatment of the carpal tunnel syndrome, we use to release this ligament with an approach which is quite aggressive, and usually you have to perform a very long incision of multiple centimeters. The minimal invasive approach is different, obviously, and I will show you later on, but it is basically based with a very small incision of just 1 centimeter. Okay, I will show you a brief video. I hope you can see the video. This is there's really small axis. As you can see, the patient is located in that direction. It has applied a tourniquet at the level of the arm to avoid the bleeding, and just 2% lidocaine, so local anesthetics, probably with mild sedation or with midazolam. The surgeon, with this small incision and with these continuous cuts, he's proceeding, and at a certain point, he will reach the fibrotic transverse carpal ligament. Obviously, this surgery is very technically demanding because you're not able to directly visualizing the transverse carpal ligament, but you have to feel it, okay? It's a matter of sensation and feelings. Thus, it is very technical and difficult. Okay, now he has cut the transverse carpal ligament. Again, he's not able to directly visualize the cut of the transverse carpal ligament. He's only able to feel that he has cut something very hard, which is the fibrotic ligament, and he has entered the carpal tunnel. Now, with the scissors, he will release distally the ligament, as you can see with these movements. Okay, and I will skip a little bit. I will show you. This is the release. Now he will move to the other side, and with this small incision, he will be able to release also the proximal part. He's also using a technique called finestra mobile, mobile window, where with just a small incision on the skin and using the elasticity of the skin, you are able to visualize different subcutaneous structures, okay, by just moving around the incision, using the elasticity of the skin. Okay, here he's releasing the proximal part of the fibrotic ligament. It is very difficult to visualize. Only the first operator is able to see what he's doing, and believe me, even though you are the first operator, you have to imagine a little bit the anatomy, because the skin incision is very small. We're talking about just 1 centimeter. Again, with the scissors, he's moving for proximal to release the fibrotic ligament. Okay, then he will check this, as you can see, the incision, just 1 centimeter, and then here he has checked if everything was open. Now he will close with a single knot suture. A simple knot. Okay, this is when the surgery is done. Very fast surgery with few complications, and can be done in an ambulatory setting, usually under 10 minutes. If you compare that type of skin incision to this one, okay, of multiple centimeters, you can appreciate why we can define this approach as the minimal invasive. There is also another minimal invasive approach to perform a carpal tunnel release, which is using an endoscope, so with through an endoscopic approach. But I've never seen this approach in Istituto Ortopedico Galeazzi, thus I decided to not talk about that. Okay, we can move to our, you can see here the small incision of just 1 centimeter. Okay, we can move to our second topic, which is the arthroscopic anterior cruciate ligament reconstruction. Here I decided to put a picture of Roberto Baggio because, as you have seen in Instagram, Roberto Baggio was able to recover from an anterior cruciate ligament lesion in just 76 days, which is incredible because the average time to recover is usually between 8 and 9 months. So it was a great recovery that it was believed to be almost impossible, and they have decided to write a clinical case about Roberto Baggio. He was able to recover in such a short amount of time for mainly three reasons. The first of all, obviously, the anterior cruciate ligament was reconstructed in the correct way. Second of all, he was very determined and motivated. And third of all, he did a great physiotherapy recovery with 2 sessions a day of physiotherapy, 5 days a week, and also 1 session of physiotherapy in the weekend. Okay, as previously, we can have a brief recap on the anatomy of the anterior cruciate ligament. The anterior cruciate ligament is a ligament located at the level of the knee, very important for 2 main reasons. First of all, the stability of the knee. Second of all, inside this ligament, we have multiple mechanoreceptors, which are important for the proprioception of the joint. The tear can be partial or complete, and usually it is caused by an internal rotation of the tibia, as you can see here. Typically, for example, when a soccer playing is doing a change in direction, or when you have a bad injury while skiing. Regarding the diagnosis of the anterior cruciate ligament, we have some tests that we can make. Like the most used one are the Lachman test and the anterior drawer test, where they will be considered positive if you're able to move the tibia, subluxate the tibia forward, and if they are positive, you have to do a peculiar imaging technique. In your opinion, what is the best imaging technique for visualizing the ligaments and also the meniscus of the knee? The imaging technique for the soft tissue of the knee.
Magnetic resonance?
Exactly, the MRI. MRI is the best technique, and you have to perform an MRI if you suspect an anterior cruciate ligament lesion, and obviously if the anterior cruciate, if the magnetic resonance is positive, you can decide if repair the ligament or not. Usually the ligament should be repaired if you are an athlete, if you are young, because usually when you don't have the ligament, osteoarthritis will develop early on in your life, or when you have multiple ligaments lesioned in the joint. Also, when you have symptoms, thus instability of the joint. Nowadays, the number of anterior cruciate ligament reconstruction are pretty high compared to 30 years ago. And it is reconstructed in a minimally invasive way, with a minimally invasive approach, using arthroscopy. Arthroscopy is basically a sort of a laparoscopy of a joint, where we have an arthroscope with camera and light source, an arthroscopic instrument, and a cannula where we have water. In laparoscopy, we have gas. In arthroscopy, we use water. In the past, it was mainly a diagnostic technique, and nowadays it is diagnostic and therapeutic. Okay, this is a real-life picture where you can see the knee of the patient, the arthroscopic instruments inside the joint, and through the camera you can directly visualize the inside of the joint. To reconstruct the anterior cruciate ligament, you have to, first of all, clear the old broken ligament. Second of all, you have to take a graft and create a surrogate of the cruciate ligament, and then implant this surrogate implanted this surrogate in the joint. The graft can be taken from a donor, for example, from a cadaver, even though I've never seen that, or it can be taken by an autograft. So we can use the quadriceps patellar bone autograft, the patellar tendon autograft, or the hamstring tendon autograft. I will talk later on about the hamstring tendon because it is the technique that I usually see in Istituto Ortopedico Galeazzi, and also because it is a technique that they have used to repair the cruciate ligament of Roberto Baggio. Basically, with this autograft of the hamstring tendons, we are taking the insertion of two muscles, which are the gracilis and the semitendinosus, at the level of their insertion in the tibia, which is the Zampa dock. In your opinion, what is a possible side effect of taking two tendons from these two muscles of the thigh? Possible side effects.
Anybody can answer. Don't be shy. No answer is a wrong answer, at least at the Journal Club for now.
Exactly. Also because it is a quite specific topic. So just guess, if you take out two tendons from two muscles in the thigh, what could be some side effects, even though they're not clinically so relevant?
So like the patient cannot move the muscles properly so that they can move the joint or to keep some posture?
Sort of, meaning that you're taking out a flexor, which is the semitendinosus, and the gracilis. Thus, a little bit of strength in flexion will be lost. But this is not clinically so relevant, and the benefits are way higher than the cost. But that's correct. You will lose a little bit of strength in flexion of the joint. Okay, now I will show you how the graft is taken. So again, you will perform a small incision of just 2 centimeters, and you will search the insertion of the semitendinosus and semimembranosum at the level of the tibia. So you're searching this, you're searching the insertion, which is called the Zampa dock, this one. Then you will isolate these two tendons, and with a particular instrument, you will cut it very proximal up to the thigh. This is when the graft is almost completely done. They are still inserted here. You will have to cut also here, and at the end of the day, you will have two long tendons, usually of this length, that you will elaborate. Maybe you can make them double, which is the technique that they have used in the case of Roberto Baggio, or you can make other technique like this one. But in the end, you will have a surrogate of the anterior cruciate ligament of usually 7 to 8 centimeters. Okay, so you have cleared the broken anterior cruciate ligament, the old anterior cruciate ligament. You have taken a graft. You have created a surrogate of the anterior cruciate ligament. Now you have to implant the surrogate of the anterior cruciate ligament at the level of the joint. You will create two tunnels with a drilling, with a drill, one at the level of the femur, one at the level of the tibia. You will, with a peculiar technique using wires, very complex, you will insert inside these two tunnels the graft, and you will block the graft proximally with a button, distally with a screw, which is usually, but not always, an absorbable screw that will be absorbed in the following years. Here we have two real-life pictures where we have the graft, the medial and the lateral condyle of the femur, the tibia, and this is in flexion, this is in extension. This is another structure very important to the knee, which is the posterior cruciate ligament, which is this one. Okay, this is how the drilling is made. Okay, And you have a direct visualization of the drills. These are the millimeters to understand how deep you're going with the drill. And this, at the end of the day, the reconstructed anterior cruciate ligament. Okay, this is the minimal invasive approach. Now I will show you a picture of the old technique, and you will understand better why we can call an arthroscopic anterior cruciate ligament reconstruction minimal invasive. Okay, this is what it was used to be done to reconstruct an anterior cruciate ligament. A big, long scar, very aggressive, very invasive, not tissue sparing. So as you can see from Renzi, when I discovered this, it was a kind of a shock to me. And now you can appreciate why, compared to this, we can define this minimal invasive. Okay. I can move to the last topic of my presentation, which is a unicompartmental knee arthroplasty. Unicompartmental knee arthroplasty, it is a arthroplasty, so the substitution of a joint of the knee of just one compartment, because you have to consider the knee as a joint made by three compartments. The medial compartment, made by the medial condyle of the femur and the medial part of the tibial plateau, the lateral compartment, made by the lateral condyle of the femur and the tibial plateau, and the last compartment, which is a patellofemoral, so between the rotula, that is, you cannot visualize it here, and the femur. And each of these compartments could be substituted. The unicompartmental knee arthroplasty can be defined minimal invasive tissue sparing if compared to the total knee arthroplasty, where you change every component of the knee joint, also the rotula that is not seen here, and obviously this technique is more aggressive to the tissue, less tissue sparing, and less minimal invasive compared to the unicompartmental. Obviously, to be able to implant a unicompartmental knee arthroplasty, you have to have the other two compartments in good shape, not degenerated. And also, you have to have the anterior cruciate ligament, which is functional. This is a real-life picture where you can appreciate why the unicompartmental knee arthroplasty is minimal invasive, more tissue sparing compared to the total, because here we have a smaller incision compared to this one, which is way longer. And just the medial component, just the medial part of the femur and the medial part of the tibia are substituted. Here, all the distal part of the femur and the tibia are substituted, and also this is the rotula, which is completely reverted. This is the rotula instead in the minimal invasive. It is just displaced laterally. It is not reverted. Okay, actually this is the unicompartmental knee arthroplasty is the topic of my thesis that I'm doing in Istituto Ortopedico Galeazzi. I am comparing the medial and the lateral unicompartmental knee arthroplasty. Okay, I finished with my presentation. Thank you for your attention. If you have any question or curiosity that you want to ask, feel free.
Thank you, Kiko. That was very interesting. For some reason, orthopedic surgery is always a little bit, I don't know, gives me a little bit the shakes. I don't know, but it's very cool. And also because I think knee and hip are the most common surgical procedures in Italy.
Yeah, yeah. Together with cataract surgery, the hip replacement and also the knee replacement is probably the most common performed surgery.
Yeah, also the aging population and all of that. It's
aging population, yes,
more important. So
and also everybody of us knows someone that like had an anterior cruciate ligament rupture or total hip replacement or some sort of arthroplasty.
And the less invasive the procedure is, the shorter the recovery time, the less medically impactful it is. So
yes,
important that
in the unicompartmental, which is less invasive, the surgery is faster. The patient recover in a shorter amount of time.
Mm-hmm. Yeah, that's very important, cost-wise and also quality of life-wise.
Yes.
So don't be shy if anybody has does anybody want to be an orthopedic in the audience, or a surgeon, or any kind of, maybe a wild guess or anything? If you have questions, you can definitely ask. Or you can also
I will ask you a question, like about the carpal tunnel syndrome. Like, in your opinion, how common is this condition in the general population? Like 1 in 100, 1 in 1,000, 1 in 50?
I think maybe really popular, especially among like certain group of people.
Yes, it's a very common condition. We're talking about 5 to 10% of the general population. So like 1 in 10 has or had a carpal tunnel syndrome. So it is a very common condition. Typically in a female population of 40 to 60 years of age, and we don't know yet what is the etiology of this condition. Like, we know that the transverse carpal ligament, this ligament here, becomes fibrotic and thick, but we don't know why. The etiology is not clear.
That's interesting. I wonder if they will ever find medical treatment of carpal tunnel syndrome, and how unlucky it will be for orthopedic surgeons. But anyway,
I hope not.
Yeah, I know.
So I have a question, but today, how much is diffused the minimal invasive technique in the several hospitals in Italy? I mean, is mostly performed at Galeazzi, or maybe everyone do it?
So this one, the arthroscopic reconstruction of the anterior cruciate ligament, it is the gold standard. It is done everywhere, and I hope that you will never see this, because this was probably 30, 40 years ago. So where you have an anterior cruciate ligament reconstruction, you will use an arthroscopic approach. The unicompartmental knee arthroplasty, the numbers are increasing also because the population is aging, but also because the technique is improving. Okay, because we are starting to tailor the surgery based on the patient. So this is also increasing, and you can see this in other hospitals. It's not very common. Like I'm not sure how common it is in the other hospital, due to the fact that it is technically more demanding compared to the total. You will perform in your life more total knee arthroplasty than unicompartmental. Thus, you will be better in performing total knee arthroplasty compared to unicompartmental. Regarding the carpal tunnel, it depends on the surgeon, because it is technically demanding, also this one, and the learning curve is very steep.
Yeah, I'm sure. We have seen in general, for those who have been to general surgery, or for those who will be, we have seen as how some surgeons are not really, some old school surgeons haven't converted completely to the laparoscopic approach,
Yes.
Which is understandable because it's a different technique and a complicated technique. But
yes, you have to think about the fact that the initial part of this technique is just based on feeling and sensation, which is, in my opinion, is crazy, because you don't see what you're cutting. You're just feeling that you're cutting something soft, which is a subcutaneous fat, and at a certain point you will hit the transverse carpal ligament, which is thick and fibrotic, and you will cut the transverse carpal ligament, and you will hear a peculiar sound. All this initial part, you're not seeing what you're cutting. You're just feeling, and to have that type of feeling, sensation, you need experience, and yes, it's technically demanding. While the other, in my opinion, are like the arthroscopic technique. Obviously, is not easy, but it's just it's look like a video game. Okay, so you have models, and like in Humanitas, there are some simulation center. It's easier to simulate that and to acquire some technical skills compared to this.
Nice. Okay.
And just a trivial question, but don't you think like you can use collagenasis to like melt the fibrotic tissue? Like I've seen it in the Peyronie disease, for example, that basically is a fibrotic tissue on the penis. So I don't know. Do you know if there's some study on it, or if it's done like first treatment before surgery, for example?
Honestly, I've never seen that. I've never read about that. Maybe, I mean, how can you tell to the enzyme to degrade only the transverse carpal ligament and not also the tendons and the median nerve that is beneath it? I don't know how you can do that in Peyronie, but I can imagine that a possible problem would be that you degrade the transverse carpal ligament, but you degrade also the tendons and the nerve that is beneath the ligament. So I don't know. That's a good question.
Anyway, I mean, the wrist is a more complicated joint than.
Yes, it is very packed, as you can see.
Yeah.
I hope you speak because it's very packed. And how can you stop the enzyme just at the level of the ligament and not also degrade the median nerve and those tendons? That
the tendons
maybe
just injected like very locally, at least in Peyronie. So maybe, I don't know.
Why not? That could be a solution. But the point is that this surgery, okay, you've seen it, just 4 minutes. In 4 minutes, local anesthetics, the patient can be sedated with midazolam or not. It's like going to I don't know, to a visit or to the dentistry, you know, like it's fast, it's cheap, just local anesthetics in less than 15 minutes, not even a drop of blood is lost. It's very effective.
Yeah.
But that's interesting, honestly. I've never thought about that. Thank you for the question.
Okay, guys. This was very interesting. If anybody else has another question, otherwise we can call it a day for now. And yeah, I mean, thank you very much, Francesco.
Thank you for hosting me.
It was our pleasure. It was our pleasure to learn something about orthopedics, because at least I speak for myself, but I know close to nothing about it. So thank you. And we will see you next time.
I want to notice you that there is a boom of followers in this right moment on our Instagram pages. So thank you.
Kiko, you were a good sponsor. We're going to put your face as our new logo.
Great. I don't suggest you that.
Next time, remember, for those of you who are interested, especially MD, next Wednesday, we're going to talk about the USMLE. So from somebody who has passed it in person. So make sure to be connected and to follow. Thank you very much.
We change from every Monday to every Wednesday?
We did, yes.
Okay. Thank you.
Thank you for hosting me. See you around.
Thank you, everybody.
Bye, guys.
Thank you.
Bye.
Bye.
Thank you. Thank you.